Steroids help us, they give us a window to play with. So if we can get the patients on steroids early, we can probably, in most cases, put a block on the progression. We might not reverse it, some of them will reverse, but we might just give us a little time to play with, a little time to arrange an operating theatre, to do a transfer, to come up with a diagnosis, if we don't know the diagnosis yet. So steroids are important, and the use of them needs to be expeditious, essentially. We need to work with a slightly cheesy American picture. We need to work with this group that Duncan's talking about. Meets once a week. A lot of really eminent people there. I sit in the room, think I'm surrounded by clever people. It's a great thing to be in that room surrounded by clever people. That can't come together every day. Say, I've got others a patient fantastic. So we need a smaller, tight-knit group of people who trust each other to make decisions, so we can make decisions on a 24/7 basis. So we can plan, do we need to cancel the scoliosis to sort this person out, or do we not need to, because it's the wrong thing to do to cancel this scoliosis, because there are other people who need that run off the spinal surface, that run off other units that are dealing with this. And with all that, we need to say, is this person going to live more than 3 months? Do they really want to be in hospital, coming for an operation for 4 weeks of that, 3 weeks of that? Or do we just say, actually, this is a bad thing that's happened to you, but you're better off having a radiotherapy palliative treatment and go home and not be involved with us, because we can make you know better in the time that you need to be made better. The patient has a role to play in that. These are our main goals. So, patient selection, we're looking for patient factors for the neurology, how bad they are, how complete is the deficit, how long it's been there for, and have they got the pain is due to effectively a spine fracture. Just like a hip fracture in an elderly person, that's a pretty unpleasant way to die or to spend the last months of your life. So even the most ill elderly person with a hip fracture gets their hip fixed if they had a fall at home. No matter how ill they are, they get their hip fixed, because actually the pain of the hip fracture and sitting in bed and being on, just gradually fading away in bed, they'll get that fixed. In the same way as this, you've got incredible pain in your back, which can't be treated from analgesia, you're better off having maybe a relatively straightforward operation to fix that fracture, maybe not the complex stuff. We do something simple and get you to get us sat up and etc. So we look at the patient factors, a whole bunch of stuff that we look at, scores, colonoscopy scores, scores. It's just a sort of reflection of some of the things that we should be scoring, which we probably don't as often as we should. I want to have a look at some tumours that we deal with. That's basically the lecture bit. I just want to talk about some patients that we see and the way that we manage them. So I mentioned renal tumours and the vascular nature of renal tumours. And when we hit the ball running, we do things well. When we hit the ground running, so we do things well. And sometimes we don't. This was one of the cases I think we did do things well. This patient came from a sort of Kettering way. We had these scans sent down to us, and he had this tumour. This tumour, this vertebral body. I need a better laser. There we go. Look at that. All right. So tumour of bone here. These are all pretty much all normal disc, and this dark, collapsed-looking vertebra has a tumour involved with it. Expansion of the tumour out here. What kind of tumour is it? On CT scan, see this tumour of the kidney here. So this is a renal tumour. This is on the CT. You can see it here. You see the tumour on the PET CT, which Duncan was talking about earlier. Here, what you can't do, you might just be able to see the subtleties of this. There's a little bit of activity going on down here. The femur, another common place for tumours to appear. So, what does this person need? This person needs this to not be quite so vascular, so when we operate on it, we go into examinate on the table. That would be a bad thing. We've got a tumour of the kidney, which happens to be pretty close to the tumour of the vertebral body. So it's pretty much the same approach. So we had a discussion with our renal surgeons, and we said, look, we've been taking out this vertebral body. Are you around embolization. So this is this highly vascular tumour that gets embolized by the radiologist the morning or the day before surgery. Stops it being such a vascular tumour for us. We then do an approach to the chest. Renal surgeon turns up, the kidney's sitting in front of him, he whips out the kidney, and then we fix this from the front and the back. One of my colleagues, patients on this side, and one of my colleagues operating through the back of the spine, I'm operating through the chest. We put a cage in through the chest, pop these screws in through the back, whole thing's done, kidneys out, 4 hours. And when it goes like that, it's so slick for the patients. So it doesn't always work that way, but that's ideal. If you can set it up like that, it's great. And then the trauma surgeon popped a nail in for us to stabilise the feet on a later thing. This is young lady breast cancer. This is the sort of thing I'm talking about in terms of people in the mid-30s, early 40s, young lady, breast cancer, been grumbling along for 10 years. She's had it treated for, and then suddenly explodes out of her treatment. She's got this tumour here in the cervical spine, spinal cord squished here. This is what it's supposed to look like: spinal cord, vertebral body. There's a CSF around it, and in amongst all that, somewhere is a spinal cord. Okay, and all this gubbins here is tumour. So she's come in, going weak, sort of weak arm, legs are going off. Again, referred over on the Thursday evening to us like this. We've got to cancel the half of our list the next day. She came over here from the Churchill. We've got a CT while she's at the Churchill. She's got a lesion in the level above. So this is the squashed flat vertebra here, T1. Lesion here in C7. Eroded away all the posterior structures here. Lots of tumour in the canal. And we've replaced 2 levels at the front on Friday, and then on the following Tuesday, stabilised the spine from the back. Now, she ambulated, she was mobile, she got her strength back, but sadly, 5-6 months later, she passed away. But she passed away comfortable, pain-free from her neck, she was mobile, she was self-caring. For her, a big thing, and at home, so it's a big thing. And that's her post-op MRI scan. You can see at the same level now, you can see there's a spinal cord, cleared everything away from the back, and there's a cage in the front. I've pretty much done all that. It gets more complex because the breast patient's living for such a long period of time. This is somebody who's, oncologist reassures me this person's going to live 3-4 years. Okay, and we've got a problem. The whole spine is full of cancer. Okay, we've probably got the top of the cervical spine. It's about the only bit that's fine. We've got a tumor core compression here, fracture here. All these sort of white levels are involved with tumor. So, what on earth do you do with that? And could fix the whole spine, but that would leave her very stiff, and it's a big operation. Or we could just try and concentrate on the thoracic spine and do something else. Think outside the box. You could just go for this single level, but we'd end up collapsing into levels around it. So we came to a compromise. We took out the 2 levels that were involved with that core compression, popped screws up in the neck, missed out the levels that were affected in the top of the thoracic spine, a couple more normal levels, cage, came down to the lower thoracic spine, stopped at the bottom of the thoracic spine just above the last normal level. So we have a normal level down here, because we don't want this to all just subside. That's her chest X-ray. We haven't got the post-op films on this, but she's got a cage in the front there. She's got this long construct up from the neck down to the thoracic spine. We've got those couple of worrying levels in the lumbar spine. We don't want to fuse the whole spine. So we get the radiologist to fill them with cement. Okay, so they've had a reconstruction effectively of the whole spine. She can go away and have radiation. She was home within a week. Goes off to have her adjuvant therapy. She's walking. She's pain-free. She's very happy. She's had these done as an outpatient a week later. Skip leads. It's a big complex neck that we fixed. The last challenges are the stuff that I do with Duncan, essentially, which is the en bloc resections. So patient with a chondrosarcoma, we can't just chop this away and replace this with something. This has to come out in one piece, and the tricky bit that we have is we can't sacrifice the spinal cord. Okay, so that's pretty much not an option. But we've got a tumour that's running up to the spinal cord. This grey area here is the spinal cord, the white area is the tumour. This is where it's arisen from the rib, and it's come in through where the nerve root comes out of the spine, and it's tracking up to the spinal cord. You can see it on here. This is a big tumour, bigger than you